We'd like to outline some of the key findings and recommendations from the independent evaluation of the new acute hospital inspection model which we've undertaken for CQC. Now, you've got the full report, so we plan to focus on a small number of issues linked to our recommendations.
Very briefly, what we did between October last year and May of this year was undertake a number of observations of inspections in practice, undertook many interviews with CQC inspection team members and trust hospital staff. We undertook a survey of inspection teams and hospital staff and observed several meetings. During this time, we're aware that CQC has been making a number of improvements to the acute hospital inspection model, and we've tried to take that into account in our evaluation.
I think to start with we should say that the new model gets almost universal endorsement from stakeholders, particularly and very importantly from acute hospitals themselves, and is seen as transformative, certainly in comparison with the process that it's replaced. I think it's recognised that there's been a lot of investment in regulatory design and a great deal of thought, and stakeholders see it as more credible, more authoritative, more rigorous and more in-depth. We've also found in our work with trusts a high level of goodwill and engagement on their part. There are clearly some transitional issues really to do with the scale and pace of the pilot programme, which should resolve as it moves into routine use. But that programme has provided a great testbed for experimentation and for development of the approach. There are four main areas that we wanted to focus on though, which are inspection teams and how they work, the inspection process, performance ratings and follow-up and impact after inspection.
The new inspection approach involves much larger teams incorporating a range of expertise. This allows for greater coverage, more feet on the ground, as well as a greater focus on professional judgments of quality and greater content expertise. This has been largely welcomed by the people that we've been speaking to. However, we did see variation in the confidence and expertise of some of these inspection team members. This provides an opportunity for CQC to focus on preparation and training for inspection teams, particularly around analytic expertise. Also, team selection seems so far to be based on largely pragmatic decisions based on availability of inspection team members, and more attention could be given to building a team with a set of skills and expertise that matches the focus and needs of the particular trust being inspected.
On our second theme, the inspection process, these new inspections are formidable exercises in logistics and planning, with typically 90 person days of field work on a single site acute trust and proportionately more for multi-site acute trusts. So the scale and depth of field work that's being undertaken is genuinely impressive. We saw a very intense process in those inspections, with inspection team members working very long days and spending almost all of their time in undertaking field work, with much less space for analysis and reflection and certainly for contributing to subsequent report writing. There's been a real focus on the more inductive and qualitative processes of data collection and perhaps rather less use of the more quantitative data contained in the briefing and also collected from trusts during the inspection. And it's true to say that there's been a great deal of data gathered, but some of that data has probably not been particularly directly used, either in the ratings or in the narrative of the report. I think we'd say that there's certainly scope for more preparation before inspections so that teams know what they're going to look at when they arrive in the organisation. More use of the key lines of inquiry, which provide a very helpful framework for guiding preparation, inspection and reporting, and more time devoted to data analysis and reflection for the process of reporting. Turning to the third theme of ratings, we think there's been a real welcome to the return of ratings from acute hospitals, and particularly to the fact that ratings are at a clinical service area rather than simply at a trust or a hospital level. We found in our survey that trust staff mostly agree with CQC's ratings of their own services, although agreement levels are slightly less good for services that have been rated as inadequate or requires improvement. CQC has put in place quite an extensive quality assurance and checking process to try and make sure that the ratings in published reports are reliable and consistent. But this process for rating is a very implicit one, reliant on professional judgment in taking a large and heterogeneous data set and turning it into a rating. And so reliability and consistency will be ongoing themes for consideration. between inspectors, between inspection teams, the definition of different performance level and the definitions of domains. We think there's more that can be done on this through providing guidance to inspection teams, through training in rating, using the ongoing monitoring of rating levels to check consistency, and through some simplification of the rating and domain scales.
Turning to impact, Trust staff generally found the process of inspection and the report quite helpful and definitely much more robust than inspections that they'd been involved in the past. Most trusts were aware of the issues that had been identified but saw it as an opportunity to refocus their efforts or add weight to their existing change plans. It did bring to light some issues that trusts were unaware of, such as where staff were being bullied and trust executives were unaware of it. The majority of staff thought that the Trust would take action as a result of the inspection and the report. The Quality Summit was seen as an opportunity to share findings and discuss action plans with a wider set of key local stakeholders such as CCG's Healthwatch, Monitor and Trust Development Authority. However, there was variation in how the Quality Summits were experienced and how they worked and how they were valued by Trust staff, especially where there were no major issues of concern. There was also a lack of clarity about roles and responsibilities, particularly the role of Monitor or TDA in holding the Trust to account for their action plans. We thought there was opportunity for a much more structured briefing or agenda in advance of the Quality Summit that outlined these expected roles and the outputs of the day. Also, a greater amount of time between publication of the report and the Quality Summit, which would allow the Trust and other local stakeholders to absorb the findings and think about what they wanted to do in the Quality Summit.
So to conclude, I think our evaluation suggests that the new inspection model is a very important step forward for CQC and for healthcare regulation in the acute sector. And we recognise that CQC's already been working to address many of these issues, learning from their own experience and we hope also from our evaluation, and to transfer that learning from the acute sector to other sectors. There are a set of recommendations in our report, but I think we'd finish by saying that we'd hope that CQC will incorporate some forms of evaluation into the inspection programme itself as it continues, with a particular focus on thinking about and assessing impact.